This is a 38-year-old male. He presented with complaints of swelling of the face, legs, and abdomen. So probably we are dealing with anasarca. He developed first periorbital edema, good. Later followed by pedal edema and abdominal distension, characteristic of how a renal anasarca progresses. He also complains of shortness of breath, which is aggravated on lying down position. Probably even he is having a hydrothorax, like a pleural effusion. He's on rehab center due to prior heroin abuse. Okay, prior heroin abuse. So that indicates us that patient might be having FSGS secondary to the nephrotic syndrome legacy. He's not a diabetic and hypertensive. He's not a diabetic and hypertensive. So you can rule out diabetes related nephropathy. His vitals are blood pressure is okay, 150, 80 is mildly on the higher side. Physical examination shows periorbital and 2 plus pitting edema. Breath sounds are diminished over the right infraaxillary region. So indicating either a pushed up diaphragm or a right-sided pleural effusion. There's a shifting dullness in the abdomen is present. So that indicates ascites. Urine dipstick shows 4 plus. So there's a kind of massive proteinuria. USG already shows the bilateral contracted kidneys. Bilateral contracted kidneys. So bilateral contracted kidneys is a finding of chronic glomerulonephritis. Chronic glomerulonephritis. 24-hour protein shows 6.5 grams of protein per day. So it is in the range of massive proteinuria. It is in the range of massive proteinuria. So we are dealing with nephrotic syndrome. Nephrotic syndrome, which is already probably in CKD. Nephrotic syndrome, which is almost already in CKD. And the other thing is young male, and heroin abuse is one more risk factor. Heroin abuse is one more risk factor here. Okay. Renal biopsy will most likely show what is what he is asking us. So minimal change disease usually does not progress to CKD. It has an excellent response to steroids. It has an excellent response to steroids. Okay. Membranous nephropathy query can be possible. Rapidly progressive glomerulonephritis, no. Focal segmental glomerulosclerosis, yes. So because FSGS FSGS usually remains like a causative factor in patients with HIV, heroin abuse, known case of sickle cell anemia, etc. These are all risk factors, and most commonly, what do you get in this is FSGS. I'm not saying you can't get membranous nephropathy. A membranous nephropathy is usually secondary to drug insults or SLE, or it can be due to hepatitis B and hepatitis C, like that. Secondary. Okay. The primary can be idiopathic, and primary will not have like a very good uh, response to steroids. It can progress to CKD as well. He did not give any of these risk factors here, but because he has given us a risk factor for developing FSGS, the likely answer will be FSGS. Maybe what would help us in identifying both the differential features is immunofluorescence. Immunofluorescence here would have been usually normal. Here immunofluorescence will show a granular pattern. Will show a granular pattern. So that is how we will be able to differentiate. Quickly going through all the causes of nephrotic syndrome. Nephrotic syndrome. Please work it up within these: minimal change disease, FSGS, membranous nephropathy, amyloid, and last but not the least, diabetic nephropathy. Diabetic nephropathy. Okay. So the right answer here would be focal segmental glomerulosclerosis. Okay, thank you.